Ethiopia, which is Addis Ababa. And as I was discussing with Dr. Solomon, that I have had the privilege of visiting his country several times in past 10 years, ever since I was working in BLK. I'm also credited with establishing their cardiac programs locally and training, exchange training a couple of doctors from that country. So today I'll be dealing with advances in minimal invasive interventions. And the focus is going to be the structural heart interventions in which TAVI, which is replacement of aortic valve without surgery, just like an angioplasty, is on the forefront. And several other interventions have emerged in last 2 decades. The world has really changed because everybody wants to avoid knife on their body, and they just want to fix up their ailments by needles or wires and tubes and catheters. So about aortic stenosis, I would just say that this is a very prevalent disease, especially with age. Anyone who is past the age of 70 will have a chance of almost 4% per year suffering from this disease, and octogenarians have almost to the tune of 10%. And as you know, as these patients age, the risk of having an open heart surgery to replace that valve are exponentially high. And once a patient is diagnosed with aortic stenosis, which unfortunately goes unnoticed unless somebody has symptoms or has undergone an echocardiography, if he complains of angina or syncope or heart failure symptoms like breathlessness, then his chances of dying or perishing in next 2 to 4 years are very high. In fact, at the end of 5 years, almost 100% would perish if nothing is done to them. So, medicine is not a treatment of aortic stenosis, and one has to act in time, and there are criteria. The criteria are defined on echocardiography. These are the common symptoms that they present to us with chest pain, angina. They have blackouts, they have fatigue, and they could even have breathlessness. These are classical symptoms of aortic stenosis. And when to intervene, one has to intervene once on echocardiography. If you see the mean gradients across aortic valve is in excess of 40 millimeters mercury, even if patient is not symptomatic, that's the time one should act. Otherwise, his chances of dying in next 5 years are very, very high. So the conventional treatment for aortic stenosis has been this SAVR or surgical aortic valve replacement, as you see here. And these pictures look very, very scary and horrendous. The chest has been opened, the valve is exposed, and the lower frame, the valve is being sutured around the annulus. The other option which has emerged in last 2 decades now is TAVR or transcatheter aortic valve replacement, in which, just like an angioplasty, a tube carries the aortic valve. The deceased valve is plastered on the wall of the aorta, and the new valve sits in that place and it functions like a normal valve. It's a tissue valve, just like a surgical valve given to the elderly patient, and this valve should last at least 10 to 15 years in that patient. And a simple balloon aortic valvoplasty is just limited to relieving symptoms for time being because the recurrence rate after a simple balloon plasty is very high. So it could at best be reserved for patient population who are high risk for TAVR. So once you give them a bridge by doing a balloon aortic valvotomy, and a month or two down the line, the patients are called for a TAVR, which is a lasting option. So this is a classic how the balloon will open a deceased valve which is heavily calcified as you see here. But this valve, if left alone without TAVR, would come back soon with recurrence and restenosis within a month's time. So this is the SAVR. Nobody wants surgery in the present day. Everybody is running for minimally invasive procedure, be it in gallbladder or hernia or abdominal surgeries or brain or anywhere in the body. Likewise, in heart, we have discovered TAVR as the best option for replacing these aortic valve in high risk elderly population. There could be various means and ways of reaching the heart aortic valve. One could reach from carotid arteries or from subclavian artery or directly from the aorta on opening the minimal chest, and the transfemoral, which is the commonest and the safest route of reaching the aortic valve. This is the balloon expand. There are two kind of valves available for TAVR. One is balloon expandable, in which the valve is crimped like a stent on top of a balloon, and once it sits across the annulus and it is inflated from outside body, the valve nicely sits under high pacing and it starts functioning as a normal valve. The balloon comes out of the body. The valve just remains there at the endless. So these are balloon expandable valves as shown here. The other could be a self-expanding valve as shown here. And in that zone, there are at least 5 or 6 iterations which are available to us. But in the balloon expandable, we have valve from Edward Sapien from America. The other valve which we in our country manufacture from Merrill is called as My Valve. So just two of them are there, and we are proud Indians to say that we are manufacturing as one of these balloon expandable valves, which is very, very widely used across the world. On self-expanding, there's a nitrinol frame here. The valve is inside, and there's a skirt which will prevent the paravalvular leak. And there are various iterations available from different countries, from different companies, ranging from Abbott to Boston to Medtronic and so forth. Dr. Alain Cribier from France was the first person to discover in 2002 the technique of TAVI or TAVR, and this was a balloon expandable valve as has been shown here. Uh, the classic population of severe AS is an old, very frail, lot of comorbidities as in CKD or bad lungs or peripheral vascular disease, atrial fibrillation, cancer, and liver diseases where open heart surgery is just not possible are the cases where this technique is offered, but still enjoying life despite having so many comorbidities in their bodies. The current status of TAVR is that it was started way back 2000, 2000 onwards, only for high risk
Ambani
population.
kulo ika shona shona yana.
For high risk population, but eventually it has come to stay even in moderate and low risk population, and the results have been shown to be non-inferior to the surgical replacement of the aortic valve. That is the beauty of this procedure as it has evolved in terms of reducing profile of the valve and the ease of doing procedure on a conscious patient is what has made this technique so popular. When it comes to choosing between surgical versus transcatheter, various factors have to be kept in mind, as in the risk profile, which is based on the STS PROM risk, which is calculated by putting in all the parameters of a patient. And once the patient is graded into high risk or intermediate risk, it is then that we look at various other parameters, as in the presence of calcium, which could lead to annular rupture in TAVR, or the groin, whether transfemoral axis are good or not, and the overall risk of doing a TAVR versus a SAVR. Definitely, the surgical risk is very high in elderly population. Therefore, TAVR emerges as a default choice, and we have evolved ourselves to a level where we could deal with the most complex patients, even patients who have undergone previous aortic valve replacements. We offer them valve and valve procedure. So a TAVR could be placed into a previous surgical valve, and that's the current status of this. Uh, Various parameters are evaluated, fitting them into favorable or unfavorable subset while doing TAVR. And then looking at the groins is very important. A thorough CT scan analysis is what is required before we embark upon doing a TAVR procedure. So, if we could summarize that patients who are suitable for surgical valve are the younger patients, patients bicuspid aortic valve, femoral axis is unfavorable for TAVR, low coronary ostia, where the ostium of coronary could be occluded by giving a TAVR, or multivessel coronary artery disease requiring even bypass grafting along with surgical replacement of the aortic valve, or any other factors. Whereas any person who's very old requiring a redo surgery, where opening chest again is fraught with risk, or frail patients, or patients who are high surgical risk, or femoral access is nicely available then, or chest radiation where opening chest is fraught with problems, and porcelain aorta where putting graft from the aorta is a problem, are the patients which are most suitable for TAVR. So this is how we grade them. And once done, I'll show you a few cases where the 71-year-old male who had pulmonary fibrosis and just not suitable for any open heart surgery or going on a heart lung machine had severe calcific AS area of zero point 0.5. LV is preserved, STS score is high, and the three-man show is a CT analysis of these patients where it was found to have type 1 bicuspid aortic valve, which perhaps is not the most suitable patient for TAVR. But still, surgery has a very high risk, so TAVR was chosen for this patient. But fortunately, he has a very good femoral artery access. So we did an analysis, the ECG, the echocardiography, and then the CT analysis on three mensure, where we have a close look at the annulus, size it properly, the subannular area, the supraannular area, the LVOT dimensions, the heights of left and right coronary arteries so that they're not occluded once the valve is deployed there, because that could be catastrophic, and the calcium present there, which could lead to an annular rupture if it is present at the annulus of the calcium. So, having done that thorough CT analysis and the femoral arteries at different places, the presence of calcium or stenosis, and then we start doing it and look at the metrics that what size is best suited for this patient, perhaps escalating 10 to 15 to 20% dimensions of the valve size to the annulus. And this is how it is done. We analyze in the three cusp view the aortogram, cross the valve, open the valve with the balloon first. Having done that, this is a bicuspid valve, so it needs opening. Then the valve is placed to the groin. This is a my valve, the one which is manufactured in India. And it comes almost at the 50% price of the Edward Sapien. So that's another advantage, especially for countries like Ethiopia, where people are not very rich. So this valve is placed across, and at a very rapid pacing, the valve is blown and the deceased valve goes by the side, the new valve starts functioning here. Having done that, out of the body, and the valve starts functioning like this. And the coronaries are nicely flowing through the small frame of this valve, as we see here. And the patient goes home with zero gradient, and he's doing very well. He keeps coming for follow-up, and I'm sure this valve is going to last him for at least 10 to 15 years when he would require another valve replacement, which can always be done by doing another TAVR in his lifetime. Uh, a patient where femoral arteries were not very good, a subclavian access was taken for TAVI, and again a good analysis was done. Aortic root analysis was done. Femoral arteries were not good here, as you see, they are very tiny. Anything which is less than 5 millimeter is not good for pushing the valve through the groin, and therefore subclavians were analyzed, and a cut down was done with the help of a surgeon. The valve was inserted through the subclavian artery, and having reached the aortic annulus, the valve was crossed. Balloon expansion was done at the valve. Then the valve was placed across the aortic annulus, and this is how it functions as we see here in the middle frame. So the technique is very swift. It barely takes about 20 to 30 minutes to finish it without sedation. We keep talking to the patient, and the final aortic angiogram looks perfect, and there's no PVL. So this is where we have arrived in last 2 decades journey of establishing TAVR. And today it has become a very, very swift and safe technique in our hands. Similarly, through the carotid route, TAVR can be done. If nothing is suitable for the access, be it femoral or subclavian, and therefore a 3 mensure analysis of the CT is done. Femorals are looked at, not good, lot of calcium. So we have gone through the carotid artery. The left carotid artery is chosen for this patient, and once we reach there, cross the valve, and then the whole technique is as simple as was done from the transfemoral route. That's the final angiogram. There could be transcaval TAVIs where the TAVI could be placed from the femoral vein, and from femoral vein we cross over into the femoral artery at the level of L4, L5, where the bifurcation happens, and just above that. And then the the whole thing is inserted from the venous side into the aorta, as we see here, and that is done under the CT guidance and the fluoroscopy. As we see here, a hole is made between the inferior vena cava and femoral aorta, descending aorta. A wire crosses into the descending aorta, abdominal aorta. The wire is snared with the help of a snare, and then the whole thing is pulled into the aorta from the femoral vein. And having done that, the whole gadgets start crossing from femoral vein to IVC to the thoracic, the abdominal aorta, as we see here. That's the snare which is trying to catch the wire which is crossed from IVC into the descending aorta. And the wire is taken all the way up, as we see here. And then most of the gadgets, they cross into the aorta, and the whole TAVI valve will go from the femoral side to the aorta, as you see here. The valve is going up into the descending aorta, and this is how it's done. So that's another novel way of doing TAVI. And management issues are there. These are the type of valves which are available, and longevity is an issue. So we're trying to prolong longevity of these valves beyond 15 years so that they don't require another TAVR in their lifetime. There are Resilia tissue, which is on Edwards valve, and several other developments are happening in the domain of TAVR. Bicuspid anatomies are dealt with more and more with TAVR today. The complications could be stroke, or conduction disturbances requiring pacemaker, which is now minimal, paravalvular leaks, or coronary obstruction, and they all can be avoided by meticulous planning of these patients. Cerebral embolic protection devices are available to prevent stroke during the procedure. Coronary access by basilica or various other techniques have been discovered in pure AR also, where the annulus is very big. A special valve called a GINA valve is being developed, and that could also be the way forward to treat the pure AR patient. So future of TAVR is very bright, and today in my country alone, we must have treated close to 10,000 patients, and across the globe they could be running in lakhs and lakhs of patients, several million of patients. Uh, the same valve in a reverse manner could be used in the mitral position where a previous mitral valve replacement has gone uh, bad, and we try to place another valve into that previous valve by the TAVR procedure, or what you call TMVR. And once the analysis is done on CT scan, a new LVOT, a virtual my valve, is placed, a good T is conducted, and then the same route from the femoral vein on the right side, the transeptal is performed, and through transeptal puncture, one goes into the left atrium, jumps into the left ventricle, as shown here with the help of an Agilis sheath, and you could see there's a valve already placed at the mitral position. Having done that, the transeptal hole is enlarged with the help of a balloon, as we see in the second frame, and the balloon would ensure that the hole is big enough to take the TAVR valve into the mitral position. Some flossing is done across that hole. The valve is placed across the mitral valve at rapid pacing. The valve is inflated just like a TAVR valve here, and it nicely sits at the mitral position. So that's the TMVR procedure, where the mitral valve could also be changed with minimally invasive method as in TAVR. Elderly people are happy having received this procedure. So that's the summary of what we have done. And this valve, which comes from India, has been compared with various other valves, and it has done reasonably well across many countries in the world. So with that, I submit and will leave the session open for question answers. I hope it was educative, and I'll be most glad to answer your question answers.
Sir, we have a question from Dr. George Mao. He has a case where one experienced some lump in the right hand near the palm. The heart rate is 120, pressure 110 by 90. It comes and goes. What can be the
Mhm.
cause?
The lump in the hand,
Yes, sir, right hand.
the right
Lump
hand.
in the right hand near the palm, and the heart rate is 120, pressure is 110 by 90. And this lump comes and goes.
Uh, it's difficult to comment on this. It could be a vascular lump or some kind of arteriovenous fistula in the palm, but one has to do a thorough CT scan, a contrast CT, or maybe a DSA, and then only one can find out as to what is the reason, and can also fix it by minimally invasive technique, as in put in a covered stent or some coils, and accordingly. But one has to first prove as to what we're dealing with. I can't say on this bare information.
So, sir, basically, the recommendation is to get a CT scan done or a
Yeah,
DSA done.
CT, contrast CT scan done. Yeah.
Okay. Dr. George, I hope that helps you. And, sir, one very practical aspect, logistical aspect is these minimally invasive surgeries. What are the cost implications compared to traditional open surgeries?
In India, the open heart surgeries are cheaper than West because the logistics of hospital management and bed and other things lasting for 6 to 7 days don't cost as much as in West. So surgery is definitely cheaper here. And given the fact there's a lot of invention or innovation goes into preparing these minimally invasive things, those procedures are definitely a slightly higher cost or at least at par with the surgical techniques. So this TAVR thing is in India, a TAVR compared to this surgical procedure is about double the cost. Uh, that's the equation. Whereas in West, it could be even less than the surgical procedure because in West the overheads are very expensive and their surgical procedures are much more expensive than what in India. So that's how dynamics different. But in India, we could offer this TAVR procedure for as little as 25,000 US dollars, which could
Okay.
be perhaps the least in the world.
Okay. So, sir, how most of the doctors who are attending today's talk, they are from developing countries like Ethiopia, Nigeria, Zambia,
Mhm. Mhm.
etc. So, when they face a patient and they are facing this choice to recommend, the relevant options,
Yeah.
so how do they decide that which patients are something that they could prepare a note and share with us so that we can share with you, which
So, whatever little I know about the dynamics of this country or countries surrounding this, like Kenya or Tanzania, I know that their levels of helping their population by doing these procedures are very basic and they're still evolving. They're very energetic in learning, but they're still evolving. So, close to 60% of their procedures would qualify to be complex, and those are the patients who should seek and come to countries like India where it is most cost effective. Just about the flight schedules are very convenient. The direct flight, 6 hours flights. So just have to come here for a week maximum, or maybe 3 or 4 days. Get it done, fly back. That is how we've been trying to help them. I have also helped the local talent by going there, working their lab, having licenses, and then calling them, inviting them to my lab for a year or two, and training them here, then sending them back. So the whole process is underway, and this is what my take is on the current level of skills in Ethiopia.
so
So
we
there's a
have
very large chunk of patients who need to travel for a good medical care.
okay, so we have a question from Dr. Innocent. Dr. Innocent is from Kenya. So first, great presentation, Dr. Chandra. What other preventive measures for complications associated with TAVI, that is strokes and mortality, with exception of CEPTs?
Yeah, so TAVI is all about planning. Doing TAVI is not a great job. It doesn't need very high level skills, but the whole energy should be dedicated to planning before you embark on doing a procedure. And the planning, as I said, would be a thorough CT scan, which could be conducted locally in Ethiopia. And those CT can be sent to us. And then we can plan across around that CT finding as to which valve is required, what are we going to face in terms of coronary occlusion or groin complications or stroke. And that is the way to do this procedure rather than doing it half hearted or unplanned and then landing up with complication. Because the mortality in TAVR could be very high if you are not careful about the groin. You should know pretty well that how to manage the groin, and the patient must have had a TAVR successfully, but merely because of the messed up groin, you lose your patient. So the whole thing is around planning, 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 planning. That's it.
We have a question from Dr. Ivan. Dr. Ivan is from Uganda. What is the prognosis of SAVR and TAR?
Yeah, so that's a very good question. So SAVR is a very, very well established technique for last 50 years plus, and given a choice in terms of safety, should be the default choice, in my opinion. Although I do TAVR quite a lot, but I would still prefer to do a technique which is well proven and very well established. So surgical way is the best to do it, especially if the valve happens to be a bicuspid valve or a small annulus, or patient is not very elderly. My choice, and my surgeon accepts safely to do it. I would send my patient to surgical only. But my surgeon says that the surgical risk is very high. Then I chip in and I accept those patients for TAVR. Though in the recent trials, TAVR has been established as non-inferior even for intermediate or low risk population, both self-expanding as well as balloon expandable valves. But still, on the merit of the patient, the decision should be individualized.
So, sir, at the risk of sounding oversimplification, can we say that if the surgical risk, the surgeon considers surgical risk is high, then TAVI should be
TAVI
considered.
is the way
If the
forward.
surgical risk is not considered high, then SAVR should be considered.
Exactly. Exactly. In
Okay.
fact, a lot of surgeons are learning TAVI because they know what are the problems they encounter when do surgery in a high risk population. So they are also learning TAVI.
So, sir, in that question, like we conduct these master classes for upskilling, and as you mentioned that you run a lot of programs where surgeons come and train under you. So, is
Yes.
BLK running any programs for TAVI training surgeons around TAVI, and what are the qualification criteria for them to be eligible for it?
Sure. So any interventional cardiologist, in fact, I have two fellows from Ethiopia working with me for last 2 years. They're coming to end of their session. We're going to recruit two more in the next coming years. And they were largely on learning the angioplasties. So once they're done with a thorough learning on the coronary angioplasty, which is about 1 year, the next year we induct them into the structural heart program. And we try to impart them skills on TAVR or L appendage occlusion or TMVR or any structural heart intervention. So we are running a full-fledged program in our hospital, and I would welcome any fellow who wants to come and join us. But they should have a basic knowledge of interventional cardiology before they really try for it.
Okay, so the eligibility criteria is they should be interventional
Informal
cardiologists,
interventional cardiologist, yeah.
and then they can be eligible and evaluated. But sir, as you said that the positions are very limited,
Yeah, yeah.
then let's say
It
you have
could
10
be that
applicants,
only
how do you
two
decide which
interview.
two to choose?
We go thoroughly through their biodata and look at the experience. We interview them, if not physically, then at least online, and then we close them.
There's a question from Dr. Mariam. Dr. Mariam is from Zambia, and her question is: if we are conducting annual screening for high risk groups, what are the minimum tests that should be done?
So, as far as cardiology goes, the basic screening tools will be a thorough echocardiography and ECG, the blood tests like lipid profiles, and the CRP values, HbA1c for underlying diabetes mellitus are the common tests, and sometimes even a stress test to dig out the coronary artery disease. They are classical tests which are conducted in most of the people who are past the age of 40 or 45, and especially in elderly, a thorough echocardiography. And most of the time, we dig out the necessary information, and then we start acting on the preventive aspect. And if there's an intervention required, then we act in time.
Sir, while we discuss, although this topic was around a very technical topic, but still cardiac health, heart health is something that everybody should be educated around, and there's a lot of information and misinformation that spreads. So, and you just mentioned preventive cardiology. So,
Mhm.
as a thumb rule, what are some basics that one should be aware, like lifestyle changes, like exercise, diet, etc.? What would you recommend as a cardiologist? Because I saw your photo, running photo, so I guess you are a regular runner. So,
Yeah.
what do you recommend?
You mentioned running. I think Ethiopia is on the top of the world. Most of the
And Kenya also,
Ethiopians
sir.
are the
Kenya
best
and
runners in
Ethiopia.
the world.
Yeah, yeah,
So and
marathoners.
they are very good looking, all lean and thin, very fit people. So we try to inculcate and tell the general public that you
Yes,
should be
I
very
appreciate that sentence.
Yes, Salman, I know. I know. Most of them, when I go to Addis, I see a lot of people running on the streets and conducted even the marathons being conducted in the country. So running is a very good exercise, which is a complete exercise. And on terms of eating, one has to avoid a lot of red meat, which has a very high saturated fat or cholesterol. one should rely more and more on vegetarian diets like greens and dry fruits, and avoiding saturated fat like milk and milk products, and then relying more on millets and various type of grains. That is the way. I feel stress-free life is what is required to stay healthy, and then some regimen in your life, daily routine, where you do some kind of exercise. In our country, yoga is very popular, and I personally do it, and of course, running or weight training or any other exercise, and staying happy is most important.
Okay. I think unless we have any more questions, if you have any patient like Dr. George discussed, if you have any patient case to discuss, you can. Otherwise, if you have Dr. Subhash, all of our doctors they have a relationship manager assigned, and what we encourage that many a times not every patient can afford to come to India. I mean, all these countries are developing like India. As you know, there are paying capacity differences, let's say in UP and Delhi. So
Hmm.
similarly there also, and many times they see complex cases,
Hmm.
and when they are aware that the patient in that they are aware that the patient cannot afford the trip, but as a doctor, they may benefit by sharing their notes with you.
Sure.
So we
So
always
we are
encourage to
always
do that,
open.
but if you say it, it would mean more, sir.
Yeah. So Varun, as you know, the policy of our hospital, we have been answering almost 20 queries every day from different Africa, different countries in Africa. And we are very open to solve their problems even online. If they send details to us, we'll definitely get back with a solution and a viable solution. There are a lot of times when the problems can be solved even locally. And if they're too complex, then we will find out some way where we can call them here and do their procedure in the most cost effective manner. Or if they are covered by an insurance, we could do a task much more easily. So it has been going on here ever since I'm working on the different countries.
Okay, so there's another, I mean, the fellowship part is really which is interesting to doctors. So there's a
Yeah,
question from Dr. Faira that how can they join your fellowship?
yeah,
Although you had answered this question, but if you don't mind answering it again.
yeah. The program, fellowship program.
Yes, sir.
Yeah, so as I told you, they should be in touch with us. They should send their CVs. They should be ready to face a physical interview, maybe online or coming here. And then we apprise them that you're fit to be inducted in our program. There are some local countries, regulatory bodies clear their CVs. So that part is also done by BLK. There are minimal fees also involved, and they have to make their local arrangements here to stay and food and clothing and everything. And that is how it goes. And people have been really been benefited by being with us in our lab, and we give them hands-on also at some stage.
Okay. There's a question from Dr. Innocent. Is there any module for exchange program?
Yeah, this is kind of exchange. I come to your country for a week or 5 days. You pile up loads of cases of different kinds. I do it for you. You do it. I'll be behind you as a proctor. And once I find that these some of the cases cannot be done locally, I tell you that please send them there. I'll do them there. That's the kind of exchange.
Because sir, among one of the audience, we have Dr. Daniel from Kinshasa.
Hmm.
He's the director and HOD, and
Okay.
he's a professor of neurology psychopathology. He was
Wonderful.
recently at BLK
Okay.
consulting Dr. Puneet Girdhar.
Okay.
So, and we discussed, and he wants that please run some programs which you
Mm-hmm.
can for my university. So
Okay.
I told him, I assured him that we will do it. Professor
Okay.
Daniel, here's Dr. Subhash Chandra, he is colleague of Dr. Puneet. Uh,
Okay. Sure,
Professor
sure.
Daniel is there by the name Okitundu.
Okay.
So
Okay.
we can organize, I mean, I'll request Dr. Subhash Chandra and we can discuss the modalities. We can organize a lecture for your university students. And since they are French speaking, we will organize, we have a French speaking teammate. We will organize that interpreter also. We'll work out the
Yeah, no,
details.
always open for any knowledge exchange. In fact, I would feel most happy if I have trained several of my colleagues and have really helped them in terms of treating their patients. I'll be more than happy to do it. I have enough time to spare for such activities besides my work.
Thank you, sir.
Okay. Thank you. So it was a very nice interaction, and I must say hello to all the colleagues joined us from Africa, and wish to see you more often on such programs.
Sure, sir. I think we can discuss with you, and I know you keep very busy, but we can select topics which you think should be covered, which will largely benefit our African doctor colleagues. And we can select a topic which is like more broad, like more clinical in nature, because
Yeah,
surgery, they know that with Indian help, somebody has to
yeah,
travel, but
that's
if something is clinical, they
sure.
can help more patients there. If
I'll
there are
always
no any other questions, I would like to thank you all for taking time out on a Sunday. Sunday is the only day doctors get, and that too, sometimes they get emergencies. And thanks for taking time out. And thank you, Dr.
thank
Subhash,
you, thanks a lot.
for,
Thank
for,
you
for
very
taking
much.
down a time out on Sunday, and you're traveling for making
Thanks.
this pit stop. And
No,
thanks a
thank you
lot.
so much. Bye.
I really
Bye,
appreciate
Solman.
for also for thank you very much for the discussion.
Thanks, Solman.
Thank you.
Thanks.
Thank you, Dr. Solomon.
Okay.
Thank you. Bye bye.
Thank you. Thank you. Thank you.